Oropouche virus outbreak in the Americas. Current situation according to the WHO update. Oropouche virus OROV. Discovery and origins. First identified in a symptomatic human from Vega de Oropouche, Trinidad, in 1955. Initial virus isolation occurred from a human case and Coquilitidia venezuelensis mosquitoes during an outbreak. Virus characteristics. Also known as Oropouche, especially in Spanish-speaking countries. The virus genetic material is a negative-sense ribonucleic acid, RNA, virus. Belongs to the genus Orthobunyavirus within the family Parabunyaviridie. Part of a diverse family with over 30 recognized viruses causing human diseases, including Oropouche, Ngari, and La Crosse viruses. Clinical impact. Causes Oropouche fever, resembling dengue-like symptoms. Sporadic outbreaks occur. Genomic structure. RNA genome consists of 3 molecules, S, small, M, medium, and L, large. These encode 4 structural proteins, nucleocapsid, 2 external glycoproteins, and RNA polymerase. Serogroup affiliation. Oropouche virus belongs to the Simbu serogroup. Within this group, at least 7 species complexes and 22 viruses are recognized. Situation at a glance. Oropouche virus is the causative agent of Oropouche virus disease. It is primarily transmitted through the bite of a specific insect called a midge, Culicoides pariensis. Regional impact. In 2024, there has been an increase in reported cases of Oropouche virus disease in the WHO region of the Americas. Notably, some areas without a previously recognized history of the disease are now affected. Confirmed cases and fatalities. As of July 20, 2024, a total of 8,078 confirmed Oropouche cases have been reported across 5 countries in the Americas: Bolivia, Brazil, Colombia, Cuba, and Peru. Unfortunately, there have been 2 deaths associated with the disease. Vertical transmission and birth complications. Brazil has reported cases of fetal death, miscarriage, and newborns with microcephaly, possibly related to OROV infection. From mother to fetus transmission is a concern. Spread beyond historical range. OROV has historically been transmitted in the Amazon region. However, climate change, deforestation, and urbanization have facilitated its spread to non-Amazonian states in Brazil, and even to countries where no cases were reported previously, such as Bolivia and Cuba. Public health risk assessment. The World Health Organization (WHO) assesses the overall public health risk posed by Oropouche virus to be high at the regional level but low at the global level. Current overview. Bolivia. Between January and July 2024, Bolivia reported 356 confirmed Oropouche cases. Transmission occurred in 3 departments: La Paz, Beni, and Pando. The highest proportion of cases was reported in specific municipalities. Brazil. Between January and July 2024, Brazil reported 7,284 confirmed Oropouche cases. The Amazon region accounted for 75.7% of cases, but autochthonous transmission occurred in non-Amazonian states as well. 2 fatal cases were retrospectively detected in Bahia, marking the first fatal cases due to acute Oropouche virus infection in Brazil. Colombia. Colombia reported 74 confirmed Oropouche cases. No deaths have been associated with OROV infection. These updates emphasize the need for continued surveillance, prevention and research efforts. Cuba. On May 27, 2024, Cuba reported its first outbreak of Oropouche virus disease. A total of 74 confirmed cases were reported from Santiago de Cuba province, 54 cases, and Cienfuegos province, 20 cases. No deaths have been associated with OROV infection. Peru. Between January and July 2024, Peru reported 290 confirmed Oropouche cases. The highest number of cases was reported in 5 departments: Loreto, Madre de Dios, Ucayali, Huánuco, and Tumbes. Over half of the cases were male, and the most affected age group was 30 to 39 years. The graph displays the confirmed Oropouche cases in 2024, categorized by country and the epidemiological week of symptom onset within the region of the Americas. Overview. Oropouche virus disease and its epidemiology. Oropouche virus, OROV, Oropouche virus belongs to the Orthobunyavirus genus within the Parabuniviridae family. It circulates in Central and South America as well as the Caribbean. Transmission. OROV is primarily transmitted to humans through the bite of the Culicoides pariensis midge, found in forested areas and near water bodies, or certain Culex quinquefasciatus mosquitoes. The virus likely has both urban epidemic and sylvatic, forest, cycles. Hosts and vectors. In the sylvatic cycle, vertebrate hosts include primates, sloths, and possibly birds. However, the definitive arthropod vector remains unidentified. In the urban epidemic cycle, humans serve as the amplifying host, and transmission occurs mainly via the Culicoides pariensis midge. Clinical presentation. Oropouche virus disease symptoms resemble dengue. Symptoms typically appear 4 to 8 days after the infective bite and include fever, intense headache, joint stiffness, pain, chills, and sometimes persistent nausea and vomiting. Up to 60% of cases experience symptom relapse after the initial fever subsides. Severe cases may lead to a septic meningitis during the second week of illness. Treatment and prevention. Currently, there is no specific antiviral treatment or vaccine available for Oropouche virus disease. Public health response. Regional level measures. Epidemiological alerts and updates have been issued to member states. Algorithms for laboratory testing have been developed and disseminated. Molecular testing capacity is being expanded across Latin America and the Caribbean. Interim case definitions have been recommended. A virtual collaboration space facilitates epidemiological analytics. Brazilian health authorities' actions. Entomoepidemiological actions aim to identify vector species and breeding sites. Surveillance is ongoing in all federative units. Technical visits and research support local responses. Research groups focus on laboratory information, clinical manifestations, and mosquito cycles. WHO's risk assessment regarding geographical spread. Oropouche virus outbreaks have mainly occurred in the Amazon region over the past decade. The virus persists endemically and causes periodic outbreaks in both rural and urban communities across several countries. Surveillance and prevention. Strengthening epidemiological and entomological surveillance is essential. Preventive measures need reinforcement to curb transmission and protect vulnerable populations, including pregnant women and newborns. Potential expansion and new transmission routes. The ongoing outbreak highlights the need for preparedness, especially considering the potential expansion of the virus's transmission area. Researchers are also exploring possible new vectors and transmission routes. Global risk assessment. WHO assesses the overall public health risk posed by Oropouche virus to be high at the regional level but low at the global level. WHO advise. Vector control measures. Reduce midge populations by controlling breeding sites, natural and artificial water-filled habitats. Focus on areas near human habitations. Chemical insecticides, such as deltamethrin and DEET, can be effective in preventing bites from Culicoides and Culex species. Personal protection measures. Use mechanical barriers, mosquito nets. Apply insect repellents to skin and clothing. Wear repellent-treated clothing. Laboratory diagnosis. Confirming cases through laboratory testing is essential for accurate diagnosis, outbreak characterization, and monitoring disease trends. Travel and trade restrictions. WHO advises against implementing travel or trade restrictions based on the current information available. And newborns. The Oropouche virus, OROV, transmitted by the midge Culicoides pariensis, has caused a surge in cases in the Americas in 2024, with 8,078 confirmed cases and 2 deaths across Bolivia, Brazil, Colombia, Cuba, and Peru. Brazil has reported fetal complications linked to OROV. The virus, historically limited to the Amazon, is spreading due to climate change, deforestation, and urbanization. Symptoms resemble dengue and can include severe aseptic meningitis. There is no specific treatment or vaccine. WHO rates the regional risk as high but global risk as low, emphasizing the need for enhanced surveillance and vector control.